Hello everyone. So we would be just finishing the respiratory disorders of illustrated textbook of Pediatrics, chapter 17. And one of the students are recording it as well, and they're posting it on they're uploading it on the YouTube as well. So whoever due to the weekend who cannot join, so they can join later, or they can just see on the YouTube as it's also public. And one of the comments, they were like one of the colleagues told me that one of the person said that it is not audible. So I'm using headphones. So that is why it's not audible. If somebody wants it, like if somebody has to like go through the videos, so they can do it by listening to the headphones. It's much better audio over there. I'll try to fix it, but I don't know. I'll tell one of our colleagues who is posting it. I don't know anything about, like, I'm not that tech savvy, so I don't know how to do it. So moving on, the respiratory clinical features, starting with clinical features. We reviewed it. About 50% of older children and person with cystic fibrosis develop asthma type symptoms and obstructive patterns on spirometry due to allergic sensitization. And also, sorry, I'm cutting it off again. It is just for the reading purposes, like we're reading along, we are not explaining anything, as we all are like, we know we are from the pediatric field, so we know much of the details already. So we are just going through it, like we're just doing it, reading it, not explaining each and everything. Also, it is, even if it's fast, you can always have an option of slowing it down once you're like doing the video. So it's much better like that. So moving on, and asthma type symptoms and obstructive patterns on spirometry due to allergic sensitization exposure to Aspergillus fumigatus, a ubiquitous environmental fungus. This can result in patchy chest X-ray changes, acute respiratory symptoms, chest tightness, breathlessness, and reduction in lung function. Diagnosis of allergic bronchopulmonary aspergillosis, ABP, is confirmed if they are elevated and rising specific IgE antibodies to aspergillus in the presence of clinical features. Treatment is with oral steroids and antifungal agents, metronidazole. GIT, over 90% of children with CF have pancreatic exocrine insufficiency. Lipase, amylase, and proteases, resulting in maldigestion and malabsorption. Untreated, this leads to faulty growth with frequent, large, pale, and greasy stools. Steatorrhea, pancreatic insufficiency can be diagnosed by demonstrating low fecal elastase, thick, inspissated bowel contents can cause bowel obstruction, vomiting, abdominal distension, and failure to open bowels. In units, this is called meconium ileus and frequently requires surgery. In older children, which is called distal intestinal obstruction syndrome and can usually manage medically with laxatives such as oral gastrocrafen. Other complications, the incidence of CF-related diabetes increases with age due to decreasing pancreatic and enzyme function. All children are screened annually from the age of 10 years with a glucose tolerance test or a continuous glucose monitoring system. CFRD is different from type 1 and type 2 diabetes, but has features of both. It does not present with diabetic ketoacidosis. Instead, it causes a gradual reduction in lung function or failure to gain weight, which can be difficult to identify to treat with insulin. Up to 1/3 of adolescent patients have evidence of liver disease, hepatomegaly, on liver palpation, abdominal liver function, the blood test, or an abnormal ultrasound. Only 5 to 10% require treatment. Regular ursodeoxycholic acid improves bile flow. Really, the liver disease progresses to cirrhosis, portal hypertension, ultimately liver failure. Liver transplant is generally successful in CF-related liver failure. Males are virtually always infertile due to absence of vas deferens, although they can father children through intracytoplasmic sperm injection. Some females with CF have reduced fertility due to increased viscosity or cervical mucus and poor nutritional status. Pregnancy can also cause significant deterioration in lung function. Many, however, tolerate pregnancy well. Management effective. Assisted fibrosis management requires a multidisciplinary team approach. Patients should be reviewed every 2 to 3 months and be seen by the MDT from a specialist CF center at least annually. Aim of management is to prevent progression of the lung disease, monitor respiratory, and to maintain adequate nutritional intake. Psychologists play a particularly important role in the overall general care. The psychologist repercussion of CF and the associated treatment burden on affected children and their families tends to be respiratory management. Key aspects of CF respiratory management are airway clearance, airway clearance, and the aggressive treatment of the respiratory infection. For a diagnosis, children should have twice daily chest physiotherapy to clear airways. Secretion in younger children, parents are taught to perform percussion and postural drainage. Older patients perform percussion postural drainage. Older patients perform controlled deep breathing exercise in a variety of physiotherapy devices. Physical exercise is beneficial should be encouraged. Nebulized mucolytics such as DNAs and habitonic saline decreases the viscosity of secretions and the number of effective exacerbations are treated with oral and intravenous antibiotics. Depending on how unwell the child is, intravenous antibiotics can usually given for 10 to 14 days via peripheral long line, and courses may be completed at home. Children requiring frequent courses of IV antibiotics may benefit from insertion of an implantable venous access device, cat. Respiratory microbiology samples, sputum of cough swabs are obtained at every clinic to monitor for infection. In the UK, young children receive prophylactic oral flucloxacin to prevent staph aureus infection. New islets of Pseudomonas aeruginosa should be eradicated using antibiotics nebulized and or oral or IV, which is successful in 80% of cases. If the infection becomes chronic, daily nebulized pseudomonal antibiotic reduce symptoms and lung function decline. Due to the risk of cross-infection, abortion clinics must be segregated according to cultured organisms and contact between CF patients is avoided. Bilateral lung transplantation is the only therapeutic option for end-stage CF lung disease. This is infrequently needed in children. Survival at 5 years is less than 50%. Medical assessment and expert post-transplant care are essential. Nutrition management, dietary status should be assessed regularly. Pancreatic insufficiency treated with oral and direct pancreatic replacement therapy taken with oral meals and snacks containing fat. Doses is adjusted according to fat content and clinical response. In most cases with CF, a normal healthy diet is encouraged in some with more advanced disease. Additional calories are required. This can often be achieved with nutrition supplements, but in some overnight feeding via gastrostomy is used. Children who are pancreatic insufficient also require fat soluble ADEK supplements, CTFR modulators. These are three broad classes of drugs that can alter the function expression of CFTR gene, potentiators, correctors, and amplifiers. The CFTR potentiators, such as ivacaftor, enable CFTR protein at the cell surface to function more classically, effectively as a chloride channel. In patients with a class 3 mutations, such as G55-1D, that reduce sweat chloride to near normal levels and increase the lung function and weight. CFTR correctors such as Mrcpch and tezacaftor and elexacaftor help CFTR protein to fold correctly and inject to the cell surface. When used in combination with the differentiator ivacaftor, they show promising results in addition to the common P508del genetic mutations, although they are not as beneficial as ivacaftor in patients with class 2 mutations. Recent studies using a combination of two correctors, potentiation triple therapy, have shown Exciting result in older children and young people, homozygous and heterozygous with C5 many find that they feel better with increasing appetite, weight gain, in some cases improve lung function. The ability of this treatment varies by country and not all combinations and implementation is suitable treatment despite early hopes. Gene therapy has not yet proven to be useful treatment in CF. Cystic fibrosis, the commonest inherited life-limiting condition affecting Caucasians is multisystem disorder affecting the lungs, pancreas, and pancreas. Treatment aims to prevent progressive respiratory failure due to repeated cycle infection, maintain adequate working nutrition. New treatments with CFTR modulators appear to after some drugs. The bullet point is 65% should be considered in any child with recurrent infection, loose tools, or potting rate. Next one, sorry, this figure, periodic review of a child with cystic fibrosis. Siblings may be affected if there's a recessive condition. Sweat, salty, may lead to dehydration, hot weather. CV line, put a cath for intravenous antibiotics to aggressively treat infection. Chest determine if hyperexpansion due to air trapping, Harris circles, pools, and split decreps, or split weeds, chest infection, clubbing of fingers. Scar from operation from a coronal iris is neonate into deep potential complication, nasal polyps, sinusitis, rectal collapse, allergic bronchopulmonary, respiratory BPA, diabetes mellitus, often insulin dependent, as it has both cirrhosis and portal hypertension, distal intestinal obstruction syndromes, meconium island sequelinant, and pneumothorax with recurrent hemoptysis, concern about infertility in males. Oxalis sputum acute or chronic, colonization pseudomonas, agenosa, or bronchocerebral asphasia. Growth, abnormal growth, nutrition, testosterone, overnight feeding for extra calories, pancreatic urine insufficiently, takes suction, pancreatic replacement therapy, weakling, fat soluble, vitamins, review of chest problems, spiromotor deterioration, regular breathing exercise, physiotherapy and exercise, and older children. Bronchodilatry therapy is a optimal chest infection, acute or chronic virus treatment, nebulize anti-pseudomonal, anti-person DNAs, avoid of direct contact with other affected patients other than family members, general overuse, full intensive performance, specific problems, exploratory review of cystic fibrosis, specific problems with managing their disease, psychological needs. Next one is primary ciliary disconnection is usually autosomal suspicion, which results from abnormal structural function cilia lining the sphincter. This leads to impaired mucociliary clearance. Affected children have recurrent infection in the upper and lower respiratory tract, which, if untreated, may lead to bronchiectasis. They characteristically have a recurrent productive cough, purulent discharge, and chronic ear infection during the development. Action to cilia allows lateralization to occur. This is crucial to determine which side organs develop, the heart of the left and the liver on the right. And the ciliary action is responsible for normal oversitis, and almost 50% of children basically have Carter syndrome with dextrocardia and situs, and those the major organs are in the mirror position of normal. The diagnosis of PCD is made by examination of structure and function of cilia of nasal epithelial cells, brushed from the nose in a combination of genetic testing. Nasal nitric oxide is almost always low and can be used as a screening test prior to cilia studies. Treatment is as for other causes of bronchiectasis. Immunodeficiency may develop severe, unusual, recurrent chest infections. The immune deficiency may be secondary to an illness, malignant disease treatment such as corticosteroids or chemotherapy. Less commonly is due to HIV infection or primary immune deficiency. Different types of immune deficiency predisposed to different lung function infections. IgG deficiency predisposes to infections with polysaccharide encapsulated bacteria such as step pneumonia cell mediated immune deficiency make one susceptible to opportunistic infections as pneumocystis, giardiasis, fungi, and neutrophilic killing defects predisposed to staph infection. Sleep disoriented breathing during REM, rapid eye movement sleep, the control of breathing becomes unstable. There is a relaxation of the voluntary muscles. The upper airway chest, this makes upper airway collapse more likely. Sleep disordered breathing occurs either due to air obstruction, central And central hyperventilation or a combination of both. Key aspects include loud snoring, witness pauses in breathing, apneas, restlessness, and disturbance. However, symptoms alone are neither sensitive nor specific microelectric differs up to 12% pre-pubertal school children snore, but true estimates of the prevalence of obstructive sleep apnea resulting in gas exchange normalities range from 0.7 to 3%. Obstructive sleep apnea leads to excessive daytime sleepiness or hyperactivity, leading to learning and behavioral problems, faltering growth, and in severe cases coronary hypertension in childhood. It is usually due to upper airway obstruction secondary to adenotonsillar hypertrophy. Predisposing causes of sleep disordered breathing are neuromuscular disease, Duchenne muscular dystrophy, craniofacial abnormality, Pari-Robin sequence, dystonia of upper airway muscles, cerebral palsy, and severe obesity. Children with Down syndrome have anatomical upper airway restrictions as well as hypertonia and are particularly at risk. These high-risk groups should be screened for sleep disordered breathing. The most basic assessment is overnight pulse oximetry, which can be from a child's home. The frequency and severity of periods of desaturation can be quantified. Normal oximetry does not include the condition, but means that several physical consequences are unlikely. Polysomnography is required in more complex cases. This includes monitoring of heart rate, respiratory effort, airflow, carbon dioxide, and view recording. It provides more information about gas exchange and can distinguish between central obstructive events. Sometimes more detailed physiological assessment is needed to assess neurological arousals and sleep staging. If adenotonsil hypertrophy is present, adenotonsillectomy, usually dramatically improves the condition. Medical treatments such as topical steroid, nasal sprays, and antihistamines may improve symptoms. Mild cases, if severe hypoxemia is seen on the sleep study, there is increased risk of perioperative complications for children with other sleep-related breathing disorders or persistent obstruction following medical and surgical intervention. Nasal face masks, continuous positive air pressure, CPAP or BiPAP may be required, which is bilateral positive air pressure. Congenital central hyperventilation syndrome is a rare congenital condition resulting in disordered central control of breathing as well as other autonomic dysfunctions. Severe cases of life-threatening hyperventilation occurs during sleep, which may result in death in infancy. Long-term ventilation during sleep is the mainstay of treatment. Sleep disorder, obstructive apnea. Sleep apnea is usually due to adenotonsillar hypertrophy and surgical removal tonsils. Adenoids may improve symptoms markedly. Respiratory care in children with complex needs. Tracheostomy. The number of children of all ages with tracheostomy is increasing. Indication are listed in this table. If a child before adenotoxin, no, this is for the cardiorespiratory monitoring child with obstructive sleep apnea, that is regulatory and periodic causes associated with oxygen desaturation and post anticonvulsively, the breathing is regular. If a child with a tracheostomy develops sudden severe breathing difficulties, it may be that the tracheostomy tube is blocked, with secretions need urgent suction and treatment. If this does not relieve the difficulty in breathing, respiratory support is given via the tracheostomy tube. All children with tracheostomy should have a spare tracheostomy tube with them at all times and a carer competent to change it. The indication of tracheostomy children, narrow airway, subglottic stenosis, laryngeal anomalies, atresia, hemangiomas, webs, Pari-Robin sequence, small joint soft palate, other craniofacial anomalies, Cruzon disease, lower airway anomalies, severe tracheal bronchodilation, long-term ventilation muscle weakness, head and spinal injury, vein artificial ventilation, any prolonged period of ventilation and airway protection to facilitate clearance of secretions. This is a long-term non-invasive respiratory support given overnight by nasal mask to a child of muscle weakness. Long-term ventilation, an increasing number of infants are receiving long-term respiratory support. Preterm infants with severe bronchopulmonary dysplasia may require additional oxygen for many months. Children with sleep disordered breathing due to neuromuscular disease such as Duchenne muscular dystrophy will benefit in both quality and duration of life from nocturnal respiratory support. This requires BiPAP, bilateral positive pressure, which can be delivered non-invasively by a nasal mask or full face mask. Children who have severe respiratory failure may need 24-hour respiratory support via tracheostomy, and in some severe cases, progressive conditions, difficult ethical decisions need to be made about admissions for intensive care and whether to initiate long-term ventilation. So this is about it, and we had to start CVS as well. Cardiac disorders will do it tomorrow. So thank you very much.